Okay, so how's everybody doing today? How was chapter 7 for everybody?
Challenging.
How was chapter 7? Other than anybody else thought it was challenging?
It was difficult.
Okay.
Yes.
It was.
It's the most challenging so far, huh?
Yes.
And the reason it's the most challenging so far is, like I said before, I've said 1,000 times, and I'll just reiterate again, is that prior to now, the rest of the information was basically remembering what we're reading, retaining the information so we'll know which answers to pick on the test. So now we're getting down to the hands-on portion, and the portion where either you know it or you don't. There's nothing you can really read and remember and retain for the answer. It's actually doing it, and either you know it or you don't. So as we can see, it's gotten more challenging. So chapter 7 was medical record documentation and coding, and I thought it was really good. What do you think about the PowerPoint? Was it put together really good?
Yes.
Yes.
Okay. Okay. So I had to make sure I put it together really good so you can retain the information that you definitely need to know. Okay, so chapter 7, medical record or documentation of medical records. So we'll go over this first, and then we'll go over the quiz. Get these notes right here because I made a lot of notes. Because not only are we going to go over the answers, I want to make sure, you know, that we know why the answers are the answers. Here we go. Okay. Here, okay, here we go. The importance of appropriate medical record documentation. So let me put this on to the side. Here we go. Okay. The importance of appropriate medical record documentation. When documentation is reviewed, it is inclusive, which means it includes, is inclusive of the clinician's observation of signs, symptoms, and complaints. Okay, so we'll get into it more in as we go into chapter 7, but while we're here, as it's saying that the clinician's observations of signs, symptoms, and complaints. Anytime that we go to the doctor, the hospital, or whatever, it's usually because of a complaint, some symptoms, some signs, something is going on that makes me say that I need to go and see somebody. So like I said, we'll get more into it in chapter 7, but that's your chief complaint. Your chief complaint. So when documentation is reviewed, it is inclusive of the clinician's observation of signs, symptoms, and complaints. The quality of care is subject to increase when the documentation is proper, because the providers can use this information to treat the patient. Also, documentation of each diagnosis code affects payment. Stop here. So let's start with the quality of care is subject to increase when the documentation is proper. That is absolutely correct. And we talked about quality care last week and the week prior. So the quality of care is going to, and it says subject to increase, but it has no choice but to increase. The quality of care will increase when the documentation is proper, because if the clinician properly documents the things that's going on with the patient, every diagnosis, capture it, everything, then they're able to manage those diseases and conditions better. And not only are they able to manage it better, it affects the payment. So you get paid according to, in risk adjustment, you're paid according to the RAF score, the RAF, risk adjustment factor score. So documentation of each diagnosis code does affect the payment. Inaccurate and incomplete documentation can cause inadequate payment to providers and risk adjustment payers. We also talked about this in the previous lesson in regards to payments having to be adjusted after audits. After they go and audit your medical records, they have a chart retrieval, which means they're retrieving the charts and those selection of those 5 charts. And then after the chart retrieval, then we're doing chart review, where they're reviewing the chart. So if you have inaccurate or incomplete documentation, then it can cause inadequate payment. Either that means that you didn't capture the diagnosis that you should have and you're missing some of the payments, or you capture diagnosis that you do not have the documentation for, which means you was not supposed to capture it if you do not have anything to support that code being on that chart. So the importance of appropriate medical record documentation, again, acceptable risk adjustment data collection sources. So when I say acceptable risk adjustment data collection sources, places that are acceptable for you to collect data from. So just like we have covered entities, we have risk adjustment specialties that are covered and some that are not covered. We talked about that, just an example off the top of my head. Standalone dialysis centers, we can't code risk adjustment from those. It's not a covered entity. So when we're getting information to collect the data from the risk get the risk adjustment scores and capture these diagnoses, we have acceptable data collection sources, acceptable sources we can get the information from. And these acceptable sources are physician services, outpatient or inpatient, of course, hospital inpatient and hospital outpatient medical records. So when you get to coding risk adjustment for whatever company you're working for, then you're going to see medical records from physician services, hospital inpatient and hospital outpatient. You're not going to see any from standalone dialysis centers, home health medical record notes. You're not going to see those. So data collection sources. So when ensuring appropriate hospital inpatient records are adequate, ensure there are both admission and discharge dates. So basically they're saying when you're looking through the medical records, when you're working for these insurance companies, these health plans, or this company or this entity that you're working for, and when you're coding your charts, and if they are hospital inpatient records, then you have to ensure that both the admission and the discharge dates are on the medical record. This is something you need to know and not nice to know. I think I got that from Roxy or Carrie. I can't remember each one. I mean, which one, but I liked it. Need to know versus nice to know. I'm gonna use that forever. I might owe you. So that's something you need to know. When ensuring appropriate hospital inpatient records are adequate, we have to make sure that the admission date and the discharge date is present on the medical record. Make sure it's present. So inpatient hospital records must also include the signed discharge summary. Inpatient hospital records must also include the signed discharge summary. So the discharge summary, I want anybody in here, of course we got our nurses on the call, we got our little medical field on the call. So anybody want to let us know what a discharge summary is? Anybody want to just tell us what a discharge summary is?
It's pretty much just it's the diagnosis codes. It includes the dates of the duration of the services. So let's say the person was admitted on November 2nd to November 9th. It would include that and all the diagnosis codes on there. And that could be signed by once that's signed by the provider, it kind of keeps things more simple because you can code from that.
There we go. So it's pretty much a summary of all of your diagnoses and your records or your tests or your labs of everything, with all of your information that you have or whatever you got done while you was in that inpatient stay. So standalone consultations must contain the consultation date, and the standalone discharge summaries must contain the discharge date. The discharge summaries must contain the discharge date. That's need to know. You want to have standalone consultations, they must include the consultation date. And the standalone discharge summaries must have the discharge date. So you know how you go to the emergency room, or like we're talking about now, inpatient stay. They're going to give you your papers at the end, once you leave, and what they prescribe for you, what they diagnose you with, what you can do to treat it at home, or how do you take your medications, or whatever the case is. Everything that you need to know about what was going on with you during that stay, whether it was over the emergency room or whether you was admitted for a couple of days, is going to be included in your discharge summary. And in your discharge summary, your standalone discharge summary has to have a discharge date. We have to know when you were discharged. Have to know when you were discharged. And that's why we were talking about the number one, the hospital inpatient records. Then we have to know when you were both admitted and when they let you go. But when we're talking about the standalone discharge summary itself, without looking at the whole record, just the discharge summary, it has to have me a date of discharge. Now, different rules and guidelines are in place for outpatient and inpatient services, and we'll go more into that as well, of course. So that's why I was saying before, and I'm not sure if you guys remember me saying it, but sometimes coding is not black and white. It's not one of these things where it's this or that. Now, of course, when it comes to the guidelines and rules, there are certain rules that govern others or trump others and that you just have to follow. But essentially, sometimes it comes down to who's the payer, where the place of service is. And you'll see the word POS, and that's usually place of service, whether it was in an ambulatory service center, whether it was in an inpatient center, hospital, was outpatient, or a SNF, or a skilled nursing facility. If you see POS on a claim, that's place of service. Where's the place that this services were rendered? So there are different rules and guidelines for outpatient versus inpatient. Now there is a list to reflect covered and non-covered facilities for hospital outpatient data collection purposes. So here's the list here for facilities that are covered and non-covered. And what I mean by covered, that means if you're working for a health plan, if you're working for this insurance company and you're coding their medical records for risk adjustment purposes, for covered entities, if this person or this patient or these beneficiaries or these members were seen in one of these facilities that are covered, then you can code for risk adjustment codes here. If they were in a non-covered facility, then it's not going to be covered. So you can't code from these medical records in regards to risk adjustment code. So the covered facilities, these are need to know. You need to know which facilities are covered and which are not covered. That's going to be on the exam, what's covered and what's not covered. They want to make sure you know what charts you're supposed to code. So make sure you understand what's covered and what's not covered. So to go over pretty much the covered facilities are self-explanatory, psychiatric hospitals, children's hospitals, things like that, because children are not excluded from having from having diagnosis, diseases, and conditions that so happen to have a risk adjustment score. They're not excluded because they're children. They have diseases and conditions and things like that that has to be managed. It has to have risk adjustment scores, depending on the setting. Long-term hospitals, so it's pretty much cut and dry with the facilities that cover. So non-covered, let's go to the bottom where it says non-covered, right here, non-covered services. Lab services except pathology. So lab services are non-covered services. Somebody tell me, why do you think pathology is the exception?
Because a pathology report could actually reveal like the specific or like a definitive diagnosis.
Perfect. especially in the regards of neoplasm or cancer. Pathology is very much so used for that. So that's why pathology is the exception and non-covered services, non-covered lab services. Pathology is the exception. Need to know, that's need to know that pathology is the exception. So reasons for coding errors. So nobody asked this question. I'm not sure if you guys know. Yeah, so a few people on here are already certified, just different certifications. Some jobs, not all, because my job doesn't have it. So some jobs have productivity standards. Some jobs have accurate, no, not some. All jobs gonna have an accuracy standard. Now, not all of them may have a productivity standard, which means they want you to code 4 charts an hour, 9 charts an hour, 12 charts, 2 charts. There's productivity some places. All places are going to have accuracy. Now, that accuracy number does change. Sometimes I've saw jobs want you to have at least a 90% accuracy, but the average accuracy that I see is 95%. They want you to be 95% accurate in all of the codes, all of the charts that you're coding. They want you to be at least 95% accurate. And that's the standard at my job that I'm at now. They want me to be 95% accurate with every single chart that I code. So I have about, about 9 or 10 clinicians that I directly work with. 9 or 10 clinicians. Yeah, about 9 or 10. So those clinicians each see anywhere between 3 to 6 patients a day. So let's just say everybody saw 6 people. So that's 60 charts a day that I would have an influx of coding. And of those 60 charts a day, let's just say every day of the week. So let's just say 300 charts a week. So of those 300 charts, they want me to be accurate with 95% of my charts. So reasons for coding error. There are different reasons where there can be errors in coding. Automatically using the codes that are already included on the super bill. So the super bill is pretty much the code that the physicians or the clinicians add to the chart. So the clinicians are going to add codes on the chart. When they see a patient, they're going to add the codes on the chart. That does not mean that those codes are accurate. They don't have the coding knowledge that you do. Yeah, they know if they see, it might be left. I just had this example. I can use this example. I just had it when I was looking at my work last night. So one of my clinicians saw a patient and the patient had left breast cancer. But the clinician chose the code for unspecified breast cancer, unspecified breast, unspecified site. So I could have just rolled with the code because that's what the clinician put and just, okay, let's go to the next chart. But when you're coding, you're also acting as an auditor for the clinicians. They're not coding at the level that you are. You know the rules, you know what codes go with what, you know if there's a more specific code, you know if there's a better code. They don't know to that extent. Most clinicians I've experienced, they don't know to that extent. So when it says do not automatically use the codes that are already included, that means that when you see the clinician put the codes on there, don't automatically assume that they're right. 9 times out of 10, and I might say 8 times, but generally 9 times out of 10, then you're going to have to make some kind of corrections to those charts. They just don't have that coding knowledge that you have or you will have. So another reason for error. So that's one reason for error, that you're just using the codes that were already on the chart and it's not correct. So using generic unspecified codes because they're easier to locate. So I'm sure you've heard of ICD-9 and now we have ICD-10. So the transition, and again, the United States of America was the last country to switch to ICD-10. Everybody else had already been using ICD-10 for years. And so the governing body was like, look, America, look, the United States, everybody else is on 10. You guys are still lagging and dragging on 9. You guys have to this point to come on with it and get on 10. So in 2015, there was a transition from ICD-9 to ICD-10, which is basically saying there was the 9th edition, and this is the 10th edition or the 10th version of the ICD-10 or the of the classifications of diseases. So with ICD-10, the version from 9, the difference is 10 is more specific. 10 is very more. Does anybody on this call have an ICD-9 book? Or have ever just flipped through an ICD-9 book? Nobody? No? Okay. Okay, so I'm gonna make sure I copy some pages from my, because I got ICD-9 books and stuff. So I'll make sure I copy some pages or something like that so you can see what an ICD-9 book looks like in comparison to ICD-10. So ICD-10 is very, 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 very detailed. ICD-9 may say broken left leg versus ICD-10 is going to say broken lower left leg. So it's just more specific in things. So another reason for coding errors are just using generic unspecified codes because they're easier to locate. We're not going for easier to locate. We're going for accuracy, and we're going for selection of the correct codes using the documentation. Reporting the primary diagnosis without coding all other appropriate diagnosis codes for the encounter. Reporting the primary diagnosis, which means the primary thing that you came in for. If someone codes that without coding all of the other diagnoses that should be coded in this encounter. So if you're coming in for the flu or fever or whatever, and then you're coming in for your toenail hurting, then I'm just not coding the primary thing. I'm coding everything that's documented that's going on for this specific encounter. So when you're coding, you're taking the encounters each one at a time. So coders and clinicians. So coders and clinicians, making sure the provider adequately document disease complications and comorbidities is pertinent to risk adjustment coding. Making sure, like you're the overseer, you're the person that's going to make sure the clinicians are in line. Pretty much, you're making sure that their documentation is how it's supposed to be. Sometimes you'll get resistance from some of your clinicians, but when you build these great relationships and they respect your knowledge and you have proven that you know what you're talking about, you usually don't get much resistance from your clinicians. They pretty much kind of listen to you, and things like that. And especially if you are already in healthcare in the regards of a nurse or you're already a clinician or something, that makes it easier. And I also, you're already a nurse on the call. I think I've already mentioned it, but this is something to write down if you're a nurse, and we'll talk about it, later. But I want you guys to look into CDI nurse, Clinical Documentation Improvement Nurse. One of my mentors, that's what she did. She made a post the other day, was saying that she finished her nursing degree because there was a goal of hers and not because it was a level up in money, because she's been coding maybe about 15 years at this point, maybe 16 years. And so that's one of my friends that was making well over 6 figures from coding. So she just finished her BSN. So she was like, I didn't finish nursing to get more money because, I made more money coding than I will on my, than I have on my first nursing job and stuff like that. So nurses looking to CDI. So now she's made the transition from bedside nursing, so she's a CDI nurse, Clinical Documentation Improvement, which pretty much saying you're looking at the clinician's documentation, no bedside, no vitals, things like that. Basically administration, checking over documentation, making sure that it's there and what's supposed to be there is. So making sure the provider is adequately documenting disease complications. You have to make sure that they are documenting these complications properly. For example, if a patient has diabetes, and then now some manifestations or some complications are already automatic linkage. For example, chronic kidney disease. If you see chronic kidney disease and diabetes in the chart together, they do not have to have those linking verbiage words that says diabetes with CKD, or diabetes due to, or CKD due to diabetes, or all those linking things to show you that there's a combination code to be used. Some things, when they have diabetes, you just automatically assume. Neuropathy is one of those. Where if a patient has neuropathy and diabetes and you're reading a chart, the linking words does not necessarily have to be there. You're going to already link them together without the use of that verbiage. But for other things, you have to have that linking term. Diabetes due to this, or diabetes caused by this, or diabetes complicated, or this is complicated by the diabetes. So that's why they're saying for providers, you're going to have to make sure that they adequately document the complications. Adequately use the verbiage that's supposed to be there. And also the comorbidities that's pertinent to risk adjustment code. Now, due to the restrictions of coding guidelines, coders primarily cannot assume a cause, and I just said this in a prior phrase. Due to the restrictions on coding guidelines, coders primarily, and you see that word, you have to read, and coding is about context clues, keywords. Like I said, it's not always black and white. You have to read in between the lines sometimes, and then even sometimes you have to read in between those lines, if I'm making sense. So listen to this. Due to the restrictions of coding guidelines, coders primarily cannot. Anybody catch that? So if anybody caught that, tell me kind of what you got gathered when I said primarily cannot. I didn't just say cannot, I said primarily cannot. Which means sometimes you can, sometimes you may, depending on the situation. So due to the restrictions of coding guidelines, coders primarily cannot assume a causal relationship between disease interactions. With some disease interactions, the documentation have to support the diagnosis. With some, not all, the documentation has to support. And that's because with some diseases and conditions, it's like automatically, if you get this and you got this, it's probably linked. So we're not going to necessarily have you linked it by the documentation, primarily goes together. And these were the coding guidelines come into play, which are listed in your ICD-10 book. There's a guideline, and there are chapter-specific guidelines. Make sure to familiarize yourself with your chapter-specific guidelines. I'm not saying you have to read each guideline from A to Z, from front to back. What I'm saying is skim through your guidelines, and it'll tell you your general directions for doing this. Or if you use this code, you can't use this code with this. So if you use this code, add this code too. So this is good to be familiar with your chapter specific guidelines and not just the general coding guidelines. So some ICD-10 guidelines indicate a cause and effect relationship, and it's presumed unless otherwise documented. Okay, let me say this again because this is important. Some ICD-10-Cm guidelines indicate a cause and effect relationship. It indicates that it's presumed unless otherwise documented. So I just made the example of saying that sometimes we're going to automatically assume that some of these things are related. So we're going to read this medical record. I see this person has diabetes. I see this person has kidney disease. I'm automatically going to know that they go together. The clinician doesn't have to put with diabetes or due to. This is one of these diseases that I automatically assume there's a cause and effect, unless the clinician clearly documents and says this CKD is not due to diabetes. It's due to a renal cancer. Their CKD, their chronic kidney disease, is due to renal cancer, and it's not due to the diabetes. So that's when I will not use the diabetes combination code. Although you automatically assume that diabetes, kidney disease go together, so this E11.22, which is CKD with diabetes, unless the provider says, oh no, this CKD is due to kidney cancer. So then I won't combine it. I won't link it because the clinician is specifically saying that it's not due to that. It's due to this. Everybody follow me on it? Everybody with me so far?
Yes,
Yes.
ma'am.
Okay. Is everything coming together from what you read? Because everybody was saying this is one of the most challenging so far. So as we're going through it so far, is everybody following where you're getting it? It's making sense. It's coming together.
Yes.
Okay.
Yes, ma'am.
Okay. Perfect. Okay. Perfect. So we just talked about this, and and that's why I'm drilling it in your head. So as it come in my mind, I'll say it, and I know it's probably already down the line in the PowerPoint, but that's how important it is. If I say it a lot of times you hear me say it, it has to be super important if I keep saying it. So conventions. So you have a category in your book with what we call conventions, and with is one of your conventions. So ICD-10 guidelines in the section 1 conventions, general coding guidelines, and chapter specific guidelines. Conventions for the ICD-10-Cm. So you're going to see ICD-10-Cm, and there's another ICD-10 book, and it's mainly for inpatient services, and that's the ICD-10-PCS. So you're going to have the ICD-10-Cm, which is the book you have. And just so you're familiar with other coding books, the ICD-10-PCS is for inpatient coding. So the word with or in should be interpreted to mean associated with or due to when it appears in the code title, the alphabetic index, either under the main term or the subterm, or in an instructional note in the tabular list. The classification presumes a causal relationship between the two conditions linked by these terms. So basically saying if you're saying with, due to, those linking terms, those conventions, then it presumes a causal relationship between those two conditions. So diabetes and cerebral infarction. This is going to be so important, need to know. Need to know, need to know, need to know, need to know, need to know. So the primary unspecified diabetic code should only be used for diabetics with no complications, which I always say is typically rare. I'm not saying that all diabetics are going to have complications, but generally, if you have diabetes, there are some other things that you're going to have too. Itchy skin, dry skin, it's something that you're going to have too generally. Or CVA, so strokes. And so you can get used to the medical terms that you will see. So instead of saying stroke, most times they're going to say CVA. So if you see a CVA, you see the word CVA in a medical term, in a medical note, in a medical record, they had a stroke. So for CVAs, the primary code, which is I-63.9, cerebral infarction unspecified should not be used once a patient has been discharged from the inpatient setting. So let me stop here. Well, let me read the rest of it and then I'll break it down. So let me start over. For CVAs, the primary code, which is I-63.9, cerebral infarction unspecified should not be used once a patient has been discharged from the inpatient setting. When the patient has been discharged, the appropriate code to use will be Z86.73. Personal history of transient ischemic attack, which is a TIA, and cerebral infarction without residual deficits or defects. So if a provider documents this is a follow-up visit, please do not use I-63.9, cerebral infarction unspecified, if there are late residual effects of the stroke and is documented, please code it appropriately. So let me go through that and break that down in layman's terms. So outside of the inpatient setting, we should not be using I-63.9. Risk adjustment, most of the time you're going to be coding in outpatient setting. Like we said, there are different rules for outpatient and inpatient, and this is one example. If the person is in the hospital or comes to the hospital for a stroke, we can use the I-63.9 because they had stroke, came to the hospital, we're actively treating that now. But once they're discharged and go to the doctor for their follow-up, they're not actively having this stroke anymore. To code it as the initial cerebral infarction. You're not having a stroke at your follow-up. Does that make sense?
It makes perfect sense, because essentially, if you're in an outpatient setting and you're coding stroke, then the next train that you shouldn't be coding a stroke, because essentially that person is not there because they have, the stroke is something that would be diagnosed in the inpatient. In the outpatient, most likely it is after that person had the stroke. So maybe they have hemiplegia, maybe they have the late effect, the sequelae, the left-sided weakness, or the left-sided paralysis. Maybe that's exactly what that should have been coded in the outpatient. But that is a common mistake, to code the stroke as if the stroke is what is happening at that encounter in the outpatient setting.
Perfect. Perfect. Did everybody follow Raquel? I think this was Raquel, correct? Yeah. So did everybody follow her? Everybody get that? And I'm gonna say it again, but everybody generally followed what she said. So
Yes.
okay. So for I-63.9, if we using it, that's the stroke code. When they're coming in for a follow-up visit, they're not coming in because they're actively having that stroke right now. They've already had the stroke. They went to the emergency room. The emergency room admitted them. They stayed in the hospital for a few days, and now they're coming in for the follow-up. So I cannot use I-63.9 in an outpatient setting because you're not having a stroke. You didn't walk in the hospital, oh, I'm having a stroke this morning, so let me go for the follow-up. So we cannot use that. That's the stroke code. Remember that. That's definitely need to know, because that's going to be on the exam where they're going to try to trick you into using I-63.9. They're going to trick you. So let me tell you what we have to use and how we have to use it and why we have to use it. So going on to the next phase. When a patient has been discharged, the appropriate code to use will be Z86.73, which is personal history of TIA and cerebral infarction without, keyword, without residual deficits. So this is the thing. When we use Z86.73 for personal history of TIA or stroke, that means that this person is not having any residual deficits. Now, a lot of us know people who's had a stroke before, or, we've seen people in characters on movies that had stroke. Sometimes when you have a stroke, you have a limp to one side. You have weakness in your face where one side droops down. A lot of stuff, sometimes you have memory issues. You can't remember because it did affect your brain. So there are residual deficits sometimes when you have strokes. So if you had a stroke, discharge, you go home, you're doing your follow-ups and everything is okay. You don't have any residual deficits. There's no left-sided weakness. There's no right-sided weakness. There's no paralysis. You're not limping. Your face is not drooping. You don't have anything wrong with you. Then we use the Z86.73, which is personal history of a TIA or a CVA. Y'all follow me on that? Only use this Z code when a person had a stroke and there's nothing wrong with them after the stroke. This is the only time you're going to use personal history. Because keep in mind, in the coding world, and a clinician on this call can attest to this, in the coding world, personal history or history of means it's over. They don't have it anymore. That's what it means in the coding world. But you will find in clinicians' documentation, if a person has been known to have this disease, even if it's still present, most clinicians or most doctors and nurses, they'll say, oh, this person has history of hypertension, history of cancer. And that their doctor is really saying this person still has hypertension. They still have cancer. This is their history. But as a coder, it means something different to us. History means it's no longer there. It's not even an issue anymore. Will a clinician on this call agree with me when you say history of in the clinician world, it means this person really pretty much still has this condition. Would you agree or disagree?
I agree, and I stopped writing like that since learning about this issue as it affects the clinical documentation. Even though
Yes.
I'm not a provider, I stopped writing like that.
Right. Anybody else agree as far as when, if you work in healthcare, when, you see the terms history thrown around, it's basically to say the patient still has it. And I'm telling you, as a coder, that means me, if I'm reading history, that means you're telling me that this person doesn't have it. So that's when me as the coder are going back with the clinician and saying, hey, Dr. Jane Doe, you saying this person has a history of hypertension, but they're still on hypertension medications and their blood pressure checking was high for this reading. They're still hypertensive, right? They still have hypertension, right? Oh yeah, they do. Okay, you told me they had history of, which means it was gone. So let's change our documentation to reflect that it's still present. Is everybody following me on that one? Y'all gonna get tired of me in this call because I'm gonna ask you probably every 2 sentences. You follow me? You got it? Any questions? Because I know how this was challenging, so I want to make sure everybody understands this before we even go to the next one. Because if this
I have a question.
Come on, let's go.
Okay, so if it's an outpatient and they don't have the residual deficit, then it's the Z8673.
Mm-hmm.
But if it's an outpatient and they do have some residual deficit, what?
So we're gonna always use, no matter whether that was in an inpatient or outpatient, like once they get, okay, so we'll use the I-63 in the inpatient setting. Think about this too. When you're in an inpatient setting, usually you're in a hospital over a period of a few days.
That's true.
So your diagnosis can change. You're coming in using I-63.9 because you had a stroke because you was coming in getting admitted or whatever. Once we discharge your papers, you're not showing any residual effects or anything like that. You might have a Z, depending on how long you was in the hospital and what you're leaving with.
Okay.
So after they observed you, you've been there for a while, this number, so you'll have an I-63 on there, of course, because you came in for the stroke. But as your codes may change day by day or what's going on, if you don't have any residual effects from your stroke, because think about this, they're coding you every day you're in the hospital. They can't go from the codes you used yesterday. This is a brand new day.
Okay.
So every day that you're in the hospital, they don't just go by, oh, you came in the hospital Sunday, you're leaving next Sunday, so we're it's gonna be one large, no, every day when you get checked down by the provider, they're coding what's going on.
All right,
Every
so if a
chart for
patient,
itself.
all right, so if a patient comes to the doctor, follow up after inpatient stay, and this patient still has some weakness on the left side. So you would apply the Z8673.
No,
correct?
ma'am. The Z8673 is only if they don't have anything wrong with them. If they perfect,
That's
like
what
they
I
never
thought.
had a stroke.
Okay. That's what I thought. Okay.
If you look like you've never had a stroke before and you don't have anything wrong with you, then it's a history. It's gone. It's history. It's out the door. It's gone. So we're gonna use a Z code. And remember, our Z codes are our status code, which kind of shows the status of the patient. So it shows me that this patient's status is history of having a stroke, but you don't have nothing wrong with you. So it's, you just have a history of it. And that's good to know because if something else is wrong with you in the future, I can look at your medical records and say, oh, okay, he did have a stroke. He got a history of strokes. That's why Z codes are important. And a lot of clinicians don't really see the importance of Z codes because it doesn't always have a risk adjustment score attached, but Z codes give me a better picture. So if this person comes in to the hospital 9 years later and have a stroke, I can go back in the medical record and say, oh, 9 years ago, okay, I look at this code, I go back all through the claims data, they have a history of strokes. So this is not anything off the wall for him to have a stroke because he had one 9 years ago. This is his history. But if that Z code was not on any claims data, then I wouldn't know that this is this patient's history. Make sense?
It does. Thank you.
Okay, you're welcome. So the next one. Okay, so
Okay.
go ahead.
I got a question.
Come on.
So what if you came to the follow-up appointment and like she was saying, you still had like left-sided weakness or whatever, you would code the left side weakness?
Okay, so this one we're about to get into next. That's the
Okay.
last bullet point. So I just wanted to stay on that because I wanted to kind of drill that in your mind because I know that you're going to deal with a lot of that in real life in regards to coding in this CVA, because a lot of these clinicians, like I said, they don't know the coding rules. All they know is the patient telling me they had a stroke or whatever, and I'm using the stroke code. They don't know about personal history and this and that. They just know stroke. Okay, you had a stroke, let me use stroke code. So when you read the chart, it's up to you as the coder to say, oh, you use this stroke code in the outpatient setting, and we're not supposed to use this code. That's when you're the one to fix it and then educate the provider on why we're not using this code or why we can't or why it doesn't fit. So lastly, from this bullet point, if a provider documents this is a follow-up visit, please, and you see this capital letter, this is need to know. Whoever told me that, I'm gonna wear it out. I probably got to buy you some lunch or something because I'm wearing this need to know out. So if a provider documents this is a follow-up visit, please do not use I-63.9, cerebral infarction unspecified. If there are late residual effects, like we talked about, paralysis, left, or just whatever, memory deficits or whatever it is going on with you, if there are late residual effects of the stroke and it is documented, please code it appropriately. Please code it appropriately. So let's see. Let me show you something. Can y'all still see my screen?
Yes.
Okay, so
Yes.
let me make sure. Okay, so this is usually what a residual effects category is. I might be wrong. Nope, I'm not. Sequela of cerebral infarction right here. Okay, so usually starts at I-63.30. Okay. So we know the I-63.3 is the sequela of the stroke. So we know that's that category and everything else is a subcategory under it. So category I-69 is to be used to indicate conditions in the I-60 through I-67 as the cause of sequela. And as we know, the stroke is I-63.9, right? Which falls in this category of I-60 through I-67. So you remember how we talked about excludes, includes, and things like that, what you can and what you can't code together? So here's an exclusion. So this showing that when I use this code I-63.39, this is also pretty much saying that I cannot use these codes with it.
You mean I-69?
Excuse me?
You said I-63.3. It's I-69.3. Is that what you mean?
I-63.9.
Okay.
I-63.9 is a stroke code. So, and I'm saying right here in I-60 through I-67, this is basically saying right here that when you're using codes from I-69, which we're in here right now, which is the sequela, they're basically telling you that when you're using I-69, it's usually because of condition that's in between one of these categories is the cause of the sequela. And then to go into the exclusions, we cannot use this code, any code from the I-69 category and the Z8673, we cannot use it together. So anybody other than Roxy and Carrie or Nancy, somebody tell me why we can't use this I-69, which is unspecified sequela, and this Z86, which is personal history. Why we can't use those two codes together?
Because you can't say that you had deficit residual deficits and then say that you did have it. You can't say you did and you did not have it at the same time.
There we go. It's a conflict. It's a conflict. There we go. That's why we cannot use these codes together. Because this Z code saying there's nothing wrong with you. But this I code is saying there is something wrong with you. So we can't have a code on the same claim that says something is wrong with you, and then we can't have one that says nothing wrong with you. Doesn't match. So let's take a look at the I-69 over here to the right. So I-69 3.0, you're basically, and you know how we're saying we're going to stay away from unspecified codes if we have to. Let's stay away from them. So I-6930 is basically saying unspecified sequela of a CVA, which basically saying you got some kind of issue, we can't pinpoint it, it's unspecified, so we're going to use this code. But there are too many codes in the I-69 category to not use a more specific code. It's just too many. So just like this, let's take a look at the first one. I-69 310. That's attention and concentration deficit following a stroke. So if you can't concentrate anymore, if you can't hold your same attention span because of the stroke, we're going to use this code. If you have memory issues because of your stroke, we will use this code. If you can't really see, you got visual issues, we're going to use this code. If you got psychomotor issues, holding things or whatever the case, we're going to use this code. If you got frontal lobe, like brain function problems, cognitive problems, hey, we're using these codes. You see how it's a code for everything?
Yes, and I can also see how coding unspecified would really be a problem, because then it would be like in the I-69, for the I-69.30, the unspecified sequelae, it's almost like saying like, oh, this person has some late effect of the stroke, but we just don't know what it is.
Right.
You know what I mean? I guess if you were waiting to get test results, you probably could use that, right?
Right, perfect. So now, am I clear with everybody of when we use I-63.9, when we use Z8673, which is personal history, and when we go and grab a code from the I-69 category? If they have something wrong with them, we're going to grab a code from that, usually that I-69 category, depending on what's wrong with them. Everybody following on it?
Thank you so much. I understand.
Yes.
Okay. Okay. Was that clear for everybody? How about you, LaTonya? Was that clear for everybody?
Yes, it makes a lot of sense now.
Okay. Perfect, perfect, perfect. Okay. So you already know we got to talk about the money when we talk about risk adjustment coding, because risk adjustment coding is about the money. It's about the money. You see how every I don't care what it is, we can be talking about simply diagnosis coding alone. You see how money always comes up. Y'all notice that?
They're all money codes. CPT, IC, they're all money codes.
Money codes. It's all about the money. So if you are a coder that can capture these codes and help them get to the money, they will love you forever. They will love you forever. So financial matters and risk adjustment coding. So when you see the word risk adjustment coding, you also will see HCC coding as well, which is hierarchy condition categories coding. So if you see HCC coder, risk adjustment coding, same thing, it's synonymous. So HCC codes are driven by a calculated RAF score. The documented HCC codes are uploaded to a claims data report of current diagnosis each year. So each year, you're going to have a claims data report and a report that shows each diagnosis that was reported for that year, whether it's for outpatient or inpatient or whatever the case is. They're going to have a data claims report that shows all of that. So proceed with caution. Be aware of overcoding and upcoding of any diagnosis. So overcoding, let me explain what overcoding is. Overcoding is, it doesn't really say what you're coding, it says. You're using a more specified or upcode to get more money, but the documentation doesn't support you upcoding that. Upcoding. So overcoding, which means you'll get in trouble for upcoding. But you necessarily won't get in trouble like audit-wise with overcoding. Upcoding means you're trying to up it to get more money. Overcoding is an example of overcoding. Let's say I use two codes that that I can't use together. You know, that they don't match just by the guidelines. I can't use. I'm overusing it. I duplicated it, the code. I'm overcoding for this diagnosis. It doesn't give me more money. I just don't know the rules and I'm using the wrong codes. So upcoding is when you're trying to up some codes to get more money, which you can see why you can get in trouble for that.
Marciana, would overcoding also include let's say coding for please stop me if I'm looking at this the wrong way. Like coding, let's say if a person has like diabetes type 1 and you're also coding for like long-term use of insulin. Would that be an example of overcoding?
The reason that's not an example, and that's one of the questions that I left out in the exam, that I left it out on purpose to make a point, but I'll go over there too. So there would not be an example of overcoding because the rule says that if a person is on insulin or anti-diabetic or hypoglycemic drugs, then you have to include that Z code. It's the requirement.
Does it change the risk factor score if the person has diabetes type 1 and you don't include the insulin?
So with diabetes type 1, then it's not a requirement that they use the insulin code. It's just per rules, it's not a requirement. Let's see if I can go here. Let me show you something. Thank you for asking that question. So let me go back up. Oh, so I can use this. Let's see, diabetes neuropathy. Polyneuropathy. Okay, polyneuropathy. Okay, so you see we got here E1142. This is diabetes type 2 with diabetic polyneuropathy. And it says, use additional code to identify control using insulin. This is the code. And anti-diabetic or oral hypoglycemic drugs is the same code. So if they're on some metformin or Januvia or whatever other oral drugs, you're going to use this. They take insulin injectables, you're going to use this. It's telling you to use additional, so you have to use it. Use additional, use it too. Not maybe you can if you want to. No, you have to use this. So let me show you with diabetes 1. Let me show you the difference. So let's do diabetes 1 with polyneuropathy. And this is another thing, a little quick thing you can learn about diabetes, and we talked about it before, that with diabetes type 1 and 2, the codes are a reflection of each other. You're just going to come from the E10 category when you're talking about diabetes 1, and you're coming from E11 when you're talking about diabetes 2. So you see how I have E11.42 up here now, which is diabetes 2 with polyneuropathy. So now I'm going to go E1042. And E1042 is diabetes 1 with diabetic polyneuropathy. And do you see how it doesn't make me put the Z code? You see that? It doesn't say additional.
Oh, so this would not be an example. I see what you're saying. This would not be a good example of overcoding because it'd just be an example of bad coding.
Right, it'd be an example of you just not accurately coding. Because you have to include the Z code. That's one of the rules when you're coding for diabetes type 2. But it's not one of the rules when you're coding for diabetes type 1. You see how you have to pay attention to the guidelines, the instructional notes, and the rules, and how things can change just in an instant from just the code. But see, we're talking about diabetes, but it's such a difference when we're talking about 1 and 2 because there's a different type of diabetes. Diabetes type 1 is generally juvenile diabetes, but adults do have it, or whatever the case. In diabetes type 2 is different. So there are sometimes different rules for some similar diseases. So you see why it's important to read your instructional notes and not just go off what the code actually says, but read in red, read your notes, because things can change. So the same rules that apply for diabetes type 2 does not apply for diabetes type 1. So an example of overcoding would be if I used, let me give you a good example of overcoding. So let's say I use diabetes type 2 without complications, right? And then I turned around and used a diabetes code for the kidney disease because I see they got kidney problems. So that's an example of overcoding. That's wrong coding too, but I'm coding for the diabetes and saying they don't have any complications. Inaccurate coding, but I'm overcoding things. I'm just adding, I see they got diabetes, so I just put the diabetes code on there. Although it says without complications, I'm just coding stuff. I'm overcoding what's going on. Now, upcoding, like I said, would be an issue of this patient doesn't really have this disease, but you're gonna try to squeeze it in and use a higher level code and hope it go through when you know you really don't supposed to use it. So we talked about this before, but I want to make sure I reiterate this because you will see this a lot in the real world. So I want to kind of drill this in your brain as well while we're on this code. When you use E1122, which is diabetes type 2 with diabetic CKD, chronic kidney disease, you cannot use the unspecified kidney disease code with this code. You see, they're telling you can only use stage 1 through 6. So if you're reading their chart and the person has diabetes and then they have chronic kidney disease unspecified stage, which they has not specified the stage, you can't use this code with it because it's telling you you have to code to identify the stage 1 through 6. You can't use an unspecified stage with that code. Does that make sense to everybody? You see why it's important to read these instructional notes and it's use additional and all of that? Because if you didn't read this, you would probably think that you can use the the N18.9, which is the CKD unspecified stage, which means they're not specifying the stage in the medical record. So you see how you can't use that unspecified code with this because it's telling you that you can't. Okay, so code all noted diagnosis codes on the date of service. Diagnosis must be documented to reflect the conditions that was observed, evaluated, and addressed. Report all current diagnoses a patient has in a face-to-face encounter by approved provider types during each year. Do not code any diagnoses previous treated no longer exist or only history in nature. So remember, when we're coding for risk adjustment, we're coding per chart. We're going off what's going on in this encounter, what's going on in this chart today. Not what happened in your last follow-up 3 weeks ago. Now, of course, I can take information that I need from those charts, but generally, I'm looking at what the provider is checking out for you today. That's what I'm coding for. So, diagnostic tests tend to not be used in risk adjustment models. Often providers may list the diagnosis they are ruling out as the reason for the test instead of listing the signs and symptoms. So instead of saying they got fever, they got chills, they got this, I might say they're ruling out COVID. That don't mean you code for COVID because it says they're ruling out COVID or suspected COVID, possible COVID. And sometimes they just list the signs and symptoms. Well, when you see that possible, maybe, rule out, probably, that's not a definitive diagnosis. You cannot code for that diagnosis. So providers are then instructed to update any diagnosis findings in the addendum. An addendum is usually when I see a patient, I capture everything that's wrong with them, and then let's say I drew a lab that day, and 5 days later, the lab comes back with results. So now I create an addendum inside of that medical record, which means I'm just going back and adding addendum, ADD, add. So I'm just going back and adding more information that I didn't have at the time of the visit. So you create an addendum. So it doesn't look like you're doing any, well, you're not going to do it, the provider does it, of course. So it doesn't look like anything fraudulent or whatever. So they're just creating and adding an addendum on the chart to say, hey, I did labs at the time of their visit and the results are in, and I'm just adding the new information on the chart. So diagnosis must be documented to reflect the condition, which means the documentation has to reflect the diagnosis. that was observed, evaluated, and addressed at that visit. For me to code it, I got to know that that doctor evaluated, observed, and addressed it at that visit, not 2 visits ago, but at that visit. So report all current diagnoses a patient has. If a patient coming in with all these diagnoses and as the doctor sees them and checks it out and it's found to be true, we're going to code all current things that are wrong with you. And we're not going to code any diagnoses that were previously treated, no longer exist, or only history in nature. Everybody following so far? I'm gonna wait on the answer.
Yes.
Okay, y'all got to wake up, get some coffee. You know, I'm gonna be talkative today because I want to make sure that everybody is following. So, you know, just holler at me and say yes off mute because I want to make sure this is what it is. Okay. So ICD-10-Cm Guidelines excerpt. So I took some excerpts out the ICD-10 book, the guidelines, to kind of show you where to look if you want more information about reading all through the guidelines yourself or whatever the case. So long as you know the rules and you're picking up all of this need to know information, you can go through all the guidelines once you pass the exam. You know, long as you know the general rules for the guidelines of what you need to follow and how to code it, then you're good for passing this exam. You know, do I know all the guidelines by heart? Absolutely not. Do I want to know all the guidelines by heart? Absolutely not. You know what I'm saying? I just want to know what I need to know. You know, so you can go and read all the guidelines or memorize them if you want to, so you can be that super coded or know all the information. But these are just the sections to kind of just know this part, hit and miss, so you can know the general guidelines and what to apply and how to apply. Because the guidelines is a lot of pages, you know. That's why I said absolutely not. Do I want to know all of them? No, absolutely not. It's too much. So section 2. Section of a principal diagnosis, selection of a principal diagnosis. So principal diagnosis is primary, it's basically the primary diagnosis, principal reason you're here, you know, the ones that take precedence over whatever else that's wrong with you. So the Uniform Hospital Discharge Data Set, UHHDS, defines principal diagnosis is that condition established after study to be chiefly responsible for occasionally the admission of the patient to the hospital for care. So blah, 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 blah. I'm basically saying the reason you're coming in to be seen by the doctor. Basically, that's what your principal diagnosis is. What's chiefly responsible, the number one thing that's responsible for your admission for care. It's your principal diagnosis. So section 4, diagnostic coding and reporting guidelines for outpatient services. And remember, we talked about outpatient and inpatient maybe are governed by different guidelines. So diagnostic coding and reporting guidelines for outpatient services. A, in section 4, selection of first listed condition. In the outpatient setting, the first listed diagnosis is used in lieu of principal diagnosis. So I'm basically saying, in an inpatient setting, we're going to call it a principal diagnosis. And in an outpatient setting, we generally call it a primary diagnosis or your chief complaint or your first listed condition. So it's like your chief complaint. So the disease-specific guidelines take precedence over the outpatient guidelines. So keep in mind, we have general coding guidelines, and then we have chapter-specific guidelines. The chapter-specific guidelines tend to take precedence over general guidelines, which makes sense. We have a general rule, and then we got a more specific rule. And then the more, if we confused on which one, then we usually take the more specific rule and we apply it because it's more specific. So I'm gonna give you an example. In your ICD-10 book, in the beginning of your book, your guidelines, you have general guidelines to coding. General guidelines to tell you what to do, what not to do when it comes to coding. And then on the front of each of your chapters, A through Z, there are specific rules for that specific section. And those rules take precedence. Your specific chapter guidelines that are specific for their disease, specific for their chapter, specific for their body system, that's going to be more important than some general guidelines because it's specific to what we're talking about. Does that make sense? That your specific chapter guidelines will overrule your general guidelines. That makes sense? And how that's possible?
Yes.
Okay. So ICD-10-Cm guidelines, familiarize yourself with a few of these guidelines. Like I said, do you have to remember all of the guidelines by heart and say it like you used to say it in like the Pledge of Allegiance in the 5th grade, or like your grandma taught you how to say the Lord's Prayer? No, you don't have to know it like that. You know, you just have to understand the guidelines and the rules and know where to look. So selecting codes for coexisting conditions. So section 4, which we talked about there earlier, and we talked about A. So diagnostic coding and reporting guidelines for outpatient. If you see OP and IP, outpatient, inpatient, for outpatient services. Selection of first listed diagnosis or first listed conditions is section A in the 4, and number 4, your section 4 in your guidelines. So G, ICD-10-Cm code for the diagnosis, condition, problem, or other reasons for the encounter. You're coding for the diagnosis, you're coding for the condition, or you're coding for the problem or other reason for the visit. J, code all documented conditions that coexist. If you have conditions that exist together and they're presently being treated, they're currently an issue, we're gonna code all of them. Nothing is gonna take precedence where we're saying, oh, we're gonna code this one, but we're not gonna code this one. And again, understand this, different jobs, different risk adjustment position, different companies have different rules. All of the companies I've worked for thus far, well, with the exception of this one, because I still have to code a few things, C codes, whatever. With the exception, most risk adjustment places, jobs, healthcare plans, they do not care about any codes other than risk adjustment codes. I don't care about abdominal pain. I don't care about a fever. I don't care about anything else. Now, of course, when you have those Z codes that you have, like we have for diabetes, where it says we have to use this in addition, that's just the rule where we're going to use that Z code. But if it's just, if they have homelessness in their medical chart, and homelessness is a code for financial strife or homelessness. And we talked about sibling rivalry and things like that. So generally, you will have to capture all of those things because that's what's in a medical record. But for risk adjustment, most companies do not, I would say 98% of companies do not care about any code unless it is a rule that says you got to code these codes together. That's the only reason we care if you use it if it's not a risk adjustment code, if it just goes in a rule where you have to use it. But if there's no rule where you have to use this Z code or anything like that, we don't care if you use the Z code or not. We just want you to put these risk adjustment codes on here so we can get this risk adjustment factor up so we can get this financial funding. So a lot of places, it depends on the rules of where you work. Again, coding is not always black and white. Sometimes it's the payer, sometimes it's the employer, or whatever the specialty, whatever it is. So in the G section under 4, there's coding for your diagnosis, condition, problem, and or other encounters or visit, reason for the visit. So J, code all documented conditions that coexist. Section 2, selection of a principal diagnosis. Depend on ICD-10-Cm guidelines to guide your code selection decision. Know your guidelines so you can know you're selecting the right one. Oh Lord, EMS. Let's get into EMS. Okay. Evaluation and management code. So evaluation and management coding has 2 sets of guidelines. Do I like evaluation and management coding? It's not my favorite. I know how to, I will, but it's not my favorite. Most of the time, you're going to use these evaluation and management codes when you're working in a physician's office, where they're having doctors visits and things like that. The good thing with a risk adjustment coding, you're not coding for the level of the visit. You're not coding for evaluation and management. However, you still need to understand it. So although this is not a need to know for the exam, it's a need to know to bring all of the other stuff together, especially with the components of a medical chart. You cannot understand the chief complaint, the HPI, which is a history of present illness, the ROS, which is the review of systems, the P&E, which is the physical exam, or the A&P, assessment and plan of a medical chart. You cannot understand the components of a medical chart if you do not know E&M coding. Well, not so much as E&M coding, if you don't know the basics or the basic foundation of evaluation and management code selection. So there are 2 guidelines that govern evaluation and management. So some people still use, some companies, insurance companies or whatever, they still use the 95 guidelines when it comes to the way they're paying you. And where the way they're paying the insurance claims out for doctor's visits. And sometimes companies use the 97 guidelines. This year, which was 2021, January of this year, when the new CPT book came out, there were new guidelines to evaluation and management. And the new guidelines speak to how the new codes are being selected. So before I get down to the nitty gritty and break it down, let me just give you in layman's term some little information about E&M, and we call it E&M code, evaluation and management, E&M code. So when you go to the doctor's office, whether it's your gynecology, your cardiologist, your PCP, or whatever specialty your doctor's office you're going to get an E&M code, evaluation and management code. And it's in your CPT book. As you notice, you don't have that book because you don't need it. So I'm just giving you information to make things come full circle for you. Is that okay for you? Did I give you some extra information to make things come full circle?
Yes, God
okay.
bless your heart, because E&M
Okay.
is definitely something.
It is. It definitely is. So I just want to make sure I added this, like I said, so things can come full circle for you. So it'll also give you an explanation of, how your doctor's visits go when you go to the doctor, and it'll give you, just a inclination of how things are billed and how they collect their money and things like that. Because we already know now, 7 weeks into the class, they collect their money by what's wrong with you. And how they collect their money is the diagnosis codes you're using, the procedure codes that are being used, the DME codes being used, and things like that. So let me tell you how evaluation management works before I get to all these fancy words and all the stuff I put together on the slide. So let me give it to you in layman's terms. So when you go, so let's say you're going to your primary care doctor. Jane Doe is going to her primary care doctor because she fell out of the tree. She was trying to save her cat. She fell out of the tree and she broke her leg. That's what happened to Jane Doe. So Jane Doe is going to go to the doctor, to the doctor's office. Okay, so let's say she already went to the emergency room or whatever for the broken leg. She got a cast or whatever the case. So now she's going to the PCP or the orthopedic or whoever for her follow-up or whatever. So with E&M coding, it's based on what we call levels, from level 2 to level 5. Well, level 1, level 1 is very rare used, but we'll say from level 1 to level 5. 5 different levels for E&M management. Where the levels, and then the rules are the 95 and 97 rules, which mean there were guidelines written in 1995 to show how evaluation and management works. And then they revised the guidelines in 1997 to say, no, this is how it works. This is a better way. So people can, health plans, insurance companies, physician offices, or whoever else, they can elect to which one they use. You just have to be on the same page of, am I coding from the 95 guidelines or am I coding from the 97 guidelines? And this is something that you do not need to know because you're not going to be coding from any of those guidelines because you're just using your one book that you have. So just to make these come full circle for you. So you have levels. When you go to the hospital, when you go to the doctor's office, there are evaluation and management codes that they're going to assign to your chart, and it's levels. The lower the level, which is level 1, that means the less things are wrong with you, the less complicated issues you're having, and the less treatment that they have to give you, and the less management of care. But when you get to level 5 means you need to leave from this doctor's office right now, and we transporting you by ambulance to the emergency room. Because whatever you came in here for is so messed up, the level is so high that you're in the wrong place. We need to get you out of here to the hospital right now, ASAP. So if you're coding charts and you know get another certification and you have to use E&M coding, that's a red flag that'll get your company audited so fast when your doctor's office is coding a lot of level 5s. You mean to tell me that everybody that's coming through there for a doctor's appointment got to leave in an ambulance? Because that's what level 5 essentially means. But sometimes doctor's offices try to squeeze, and that's why they stopped doing this fee for service and we're going to risk adjustment. Sometimes doctors try to squeeze level 5s out the situation and try to justify it with documentation or whatever. But if they're not leaving out of there in the stretcher, you shouldn't be coding a level 5 for anything. A level 1 may mean somebody came in with a bee sting. The bee stung them, and you know, I got to put a little cream on it. So your E&M code visit will be a level 1. Now, if you came in there actively having a heart attack, then your visit is going to be a level 5, and we got to get you out of here. Now, if you come in here and we like managing your diabetes, we're refilling your insulin, your sugar is a little high or low, and we're checking that out. You know, you might be a level 3 because you're on active prescription medications, or a level 4 or something like that if something's going on. So everybody's following me about evaluation and management and how your levels are when you go. You might go to the doctor's office for a headache. There might be a level 1 or 2, depending on what they prescribe for you. So is everybody following me how you how they code for evaluation and management and the levels when you go to the doctor's office, and how the doctor get paid for seeing you? Depending on they get paid depending on your level. Everybody follow me on it?
Yes.
Okay. Okay, well, we can have one spokesperson that speak for the whole people. As long as I hear one yes, and I can move on. I will not move until I hear at least one yes. So that one yes gonna speak for everybody then. So I got to hear at least one yes. So evaluation and management, 95-97 guidelines. Although in ACC coding, we primarily focus on ICD-10-Cm coding, however, you must understand E&M coding. And for more physician outpatient office visits, the provider performs 3 main components. 3 main components. This is need to know. Everything that was on the quiz is need to know. So make sure you write this down. There are 3 main components that a provider performs. It's the history, it's the exam, and it's the MDM, which is the medical decision making. That's what your level is based on. When you go to the doctor's office for your headache, or when you go for a cough, or when you go for your back hurt, whatever you go into the doctor's office for, they're going to give you a level. And the level that you get is based on your history, your exam, and your medical decision making. When I mean by medical decision making, did we send her immediately to the emergency room? Did we just treat her with prescription medications? Did we just give her some over-the-counter medication? Did we not do anything but just talk to her and told her what to do when she get home? That's what MDM means, medical decision making, the decision that they make medically after they evaluate and manage what's going on with you. And it's just what it says. I'm evaluating you, which means I'm looking in your ears, your eyes, your nose, your throat. I'm checking you out. And then I am managing what I find. That's pretty much happens when you go to the doctor's office in an outpatient setting. They evaluate you, and then they manage what they find. That's why this section is called E&M, the evaluation and management section. And those codes are all numerical codes. So it's 5 numerical codes, numbers, and it's different sections. And they have an entire E&M section. They have an E&M section when you're in evaluation and management in an outpatient setting, or if you evaluation and management in an inpatient setting. Because sometimes you can go to the emergency room and then they keep you for observation. You're not necessarily admitted into inpatient status, but you're there for observation, which means they're still evaluating you and managing whatever they're observing. Y'all following, making sense? It's coming together?
Yes, ma'am.
Okay. Whoever take their phone off mute first. Remember, I told you I need at least one spokesperson. So the history. So let's go over those three components. So the history is it directs the provider to assess the chief complaint based on talking to the patient. I got taken to the patient, but talking to the patient. So the chief complaint is the reason why you're there, the reason why you came to the hospital, the reason why you came to the emergency room, the reason why you came to the doctor's office, the reason why you called and made the appointment. Even if it's nothing wrong, you're coming in for a preventative visit to just check out everything on an annual basis. That's your chief complaint for a follow-up or an annual visit. What the reason you're coming in here is your chief complaint. That's very important to know. The reason you're coming in is called your chief complaint. And that comes from your history. That's usually the first portion of the medical record that you're going to see. Is called your HPI, your history of your present illness. And that's kind of like an oxymoron because they got history and present. History means in the past and present means that's happening right now. But the name of that component to the chart is called your history of present illnesses. So it's still a history of what's presently going on with you. So your exam portion. Now, again, we're talking about components to the medical record. When a doctor sees you, these are the components that they're going to have to make sure they're in place that they're going to have on this medical record. They're going to take a history by talking to you, seeing what's wrong with you, why you're coming in, what's been going on, how long this has been happening. So your exam, your physical exam portion of medical record when the provider evaluates the patient. Now we're moving up. I go from talking to you, seeing what's wrong with you. Now I'm going to physically putting my hands on you and checking you out and seeing what's wrong with you. So your MDM or your medical decision making is determined by the number and the complexity of presenting problems. How many things are wrong with you? And of the many things that's wrong with you, how many are complex? How many are minor? How many are limited or minimal or simple? So the MDM, the medical decision making that the doctor decides what to do is managing your treatment, that's decided by the number and the complexity of the issues you have wrong with you. It's also determined by the data to be reviewed, if they have to review lab results or diagnostic testing. And it's also the risk associated with the patient's diagnosis. Once we diagnose you with cancer, what are the risks? Is it terminal or did we catch it early? Or that's what's going to determine my MDM. If we catch it early, I might can give you some medications or some oral medications and your cancer might shrink. But if I caught it late, then maybe radiation and chemo is the only thing to do. And then that puts you in risk factor even more for other conditions. Am I making sense? What the MDM medical, how they decide to what your number going to be, what your evaluation and management code is going to be. They decided by your history, your exam, and what's wrong with you and how they're going to fix it. Making sense so far?
Yes.
Okay, there we go. We got a couple of spokespeople. Okay, we woke. So your chief complaint. Your chief complaint, a medically necessary reason for the patient to seek the attention of a qualified healthcare professional. Your chief complaint is, what are you coming in here for? Your HPI, you're not going to hear anybody say your history of present illness. They're going to say HPI. So if you hear them say HPI, there it is. So you need all of these components to be able to code from. Like sometimes I might get a chart from a provider where their HPI didn't filter over. So the HPI is going to tell me, oh, 80-year-old patient, just like when you read those medical charts that I gave you guys or whatever. So your HPI is in the beginning where it tells me this is an 80-year-old patient. She lives in a modest home. She's complaining of coughing or sneezing or whatever the case. That first section in that paperwork I gave you, that's your history of your present illness. And it's based on the chief complaint. And a qualified healthcare professional will speak with the patient to get a clear picture of the reason for the visit. And the HPI must be documented. Like I said, I might get a chart that the HPI did not filter over, but the exam is there, the AMP is there, the past medical history is there, but the HPI is missing. I cannot code it. I have to send it back to their provider and say, your HPI is missing. Please provide your HPI so I can code the chart. Cannot code it without the HPI. Review of systems, you're gonna see ROS. So you hear somebody say ROS. You will not hear anybody pretty much say, I'm review a system, and say, oh, the ROS. Per the CMS, which is the Center for Medicare and Medicaid Services guidelines, the review of systems can be obtained by ancillary staff, like a nurse or a medical assistant, or through the patient completing a form. The provider must physically evaluate the ailments listing on the form to confirm the validity. I'm basically saying the patient can fill out the form. The form may say, are you having pain? Do you have anything going on with your integumentary system? Or yeah, I got skin problems. Or is anything going on with your musculoskeletal system on the form? And they may say, I have a swollen knee, or my knee has been hurting. So yes, they can take the information, and we can take the information that the patient is giving us. However, the provider must evaluate the patient to confirm what this patient is saying. I just can't go off what this patient is saying. I have to do an exam, or the physician or the clinician has to do an exam to confirm or verify that this is actually what's going on. So now keep in mind, the review of systems, and this is need to know, maybe on exam, it may ask you who can obtain information regarding the ROS, or the review of systems. And the answer could be ancillary staff or the patient. But you also must still remember that the provider has to verify the validity of the patient's ailment. So past medical and social history. It's going to say PFSH, or you might see PMH, which is past medical history. So when we're talking about past, we might talk about childhood diseases, illnesses, operations, injuries, treatments, and medication. So when we say family, did your mom have high blood pressure? Did your dad have heart problems since you're having these? Like, what's your family history? Social history. Do you drink? Do you smoke? Occasionally, every day? Your social questions. Do you work? Are you married? Are you retired? That goes into your social history. That's a part of your medical record. So your physical exam. Each body area or organ system is evaluated to correlate with the chief complaint. If they coming in and saying they got a stomach ache, then I'm gonna evaluate it. That sometimes that might consist of doing an ultrasound. But I might have to do an ultrasound to see why your stomach is hurting, so I can see what your chief complaint is and find out what's going on from you telling me the chief complaint. MDM, medical decision making. So medical necessity of encounter, number of diagnoses addressed, complexity of the treatment options, risk to patient's life. For risk adjustment, the diagnosis may come from anywhere within the note. It might come from the HPI, it might come from the ROS, it might come from the assessment and plan. Diagnosis might come from anywhere in the note. So your MDM, like we talked about, medical necessity of encounter, number of diagnoses addressed, what they addressed at the visit, how many did they address, how complex were the issues. So coding from the HPI, the chief complaint, and the past medical history. All documented current diagnoses should be coded. If it's documented, if you're currently being treated for it, you should code it. Providers might sometimes list historical diagnosis as current and vice versa. MEAT, that's the acronym used for monitor, evaluate, assess, and treat. Many diagnoses and risk adjustment model might require medication therapy. Name me a code that is not a risk adjustment code, but requires medication therapy. Do you know one? And some people might not think is as important because it doesn't have a risk adjustment score. But it is. So I'll tell you, hypertension is one of those codes. I-10, hypertension. It does not have a risk adjustment traditional score, but it has a drug risk adjustment score. And that's because 9 times out of 10, if you got hypertension, then it is treated with medications. So there's going to be a risk adjustment medication score. So many diagnoses in the risk adjustment model, they require that you take medication. Because if you notice, and that's what it's called ACC, chronic conditions, hierarchy condition categories, all these conditions are chronic in the ACC model. All these are chronic conditions. These are things that generally do not go away. And most of the time, if you're having conditions that do not go away, you're going to need some type of medication therapy to manage it. So commonly diagnosis is improperly coded. Cancer, CVA, heart attack. So we know that myocardial infarction, or MI, is simply a heart attack. It's just a technical term. Just like I can say lawyer, or I can say attorney. I can say doctor, or I can say physician. You know, I can say the janitor, or I can say environmental services. You know, so I can say heart attack, or I can say myocardial infarction. I can say stroke, or I can say CVA, cerebral infarction. I can say cancer, I can say neoplasm. So, and I'll let you know why these are commonly improperly coded. So it's commonly improperly coded because the historical versus active when it comes to cancer. A provider might say this person has a history of cancer, and then when you look in the medication list, they're still currently taking medication. So that means this is not history, this is current, and they have to code it as current. And you got to change your documentation from history because it's still here. CVA, we talked about that, not using that I-63.9 in this setting. Myocardial infarction works the same way. If it's longer than 5 weeks, then you're going to use old MI. You're not going to use the heart attack code in an outpatient setting for after so long, because they're not actively having a heart attack. It's going to be an old MI at that point, and you're going to use I-25.2. So your past medical history. Coders are required to find supporting evidence within the same date of service to substantiate the particular PMH diagnosis as current. I'll say it again. Coders are required to find supporting evidence. You are required to find supporting documentation from the clinician within the same date of service, within that date, that chart, that encounter, to substantiate certain past medical history diagnosis as current. So if it's on the past medical history list, but they're currently, okay, let's say for example, good one right here. So on their past medical history list, it says that they have breast cancer. But then if I want to know if it's still active or is this really a history, I can code from the medication, which means if I look at the medications and I see they are actively taking cancer medications, then that means the cancer is not history. That means they still actively have cancer because I use the medications to support. Again, coders are required to find supported evidence. And your supporting evidence will be from your medication list. If this provider says, oh, this patient has history of heart arrhythmia, but then when I look in the medication list and I see they're currently on cardiac arrhythmia medications, then this is just not a history. You still have cardiac arrhythmia. And I have to code it as current because I have substantiating, supporting evidence to say if this is present. So even though it's on your past list, you're still presently being treated for it. So I have to act like it's still current because it is. Everybody following me on it?
Yes.
Well, good. I'm glad you got up there.
Okay, so everything's coming full circle for everybody. Gotta accept.
Yes.
Perfect. Perfect. Okay. So example, old versus current. Chronic problems. So we got DM type 2 on insulin. So this is an example. So let's say we got this patient here now. They got DM type 2 and they're on insulin now. They had acute liver failure. They was admitted in 2019 to the hospital for it. They got an old MI. They had a CVA in 2015. They currently see a cardiologist now for congestive heart failure, and they have breast cancer. So which ones would I code as current and which ones would I code as old? Who want to take this question?
So the CVA will be old. The acute liver failure in 2019 would be old. The old MI. So I guess that's a MI over 5 weeks. So that's old. And then the breast cancer. All right, so the insulin stands out for me because the diabetes type 2, because they're on insulin. So I see that's being currently treated. Perfect. They're followed by a cardiologist for the CHF. So I see that that's currently being managed. The breast cancer is a little tricky right there just because of the fact that there's nothing saying that this breast cancer is like they're being followed by oncology or referred to oncology, or, they're on like some type of cancer, so that one would be tricky for me for the breast cancer. That one I have to plead the fifth on that.
Perfect. I love it. I love it. That's why I put it just like that. Hey, I love it. So that's why I did it like that. So I left one that was up in the air. And usually, what do we do if something is up in the air and we're not sure? What do we do then? If we're reading a medical chart, it's up in the air, we're absolutely not sure. What would our next step be?
Query the physician.
There we go. There we go. That's why I left it like this, so we'll know what to do in our cases. So we already established what's old. We already established what's current. So with the breast cancer, so you know what we can do or whatever if to avoid querying it. So we're gonna, when you query the physician when there's no more options left. Because you'll never want to be put in a position where you query the physician. Of course, it's better to ask questions, but it's also better to be on your stuff and be detail oriented and know what you know. So you don't want to query a physician and then they send back to you, oh, look here, it's there. Or did you not see this or that? You just want to make sure when I query you, I've already done my due diligence. And that's the last result is to ask you because you didn't do the right thing, So with the breast cancer, one thing that you can do to avoid or where you can look in the chart to avoid querying the patient to see whether it's active or not. Now you can still query the medication list. There we go. So if you're seeing breast cancer and you're not absolutely sure, look at the medication list. And if you don't see any medications for breast cancer or for cancer, then more than likely it's a history. But you can definitely still query the provider and say, hey, I see that the patient is not on breast cancer meds. I see it's under the history in the patient's chart. Is this active or a true history of cancer? Just so you can satisfy your own mind, you can. But if you don't see any medications, then you pretty much know this is a history of they're on chemotherapy, they're not on radiation, not on any oral drugs, pretty much history. So you can avoid querying if you look from your medication list. So coding diagnoses from review of systems, feedback from the patient along with review body areas and the organ systems, not acceptable without provider validation. I cannot just take the patient's word. I have to have validation by the provider to say that this is actually true. Based on CMS documentation guidelines, the review of systems can be recorded by ancillary staff and or the patient with provider validation. So coding diagnosis from the exam portion of the medical record. Objective findings from a physical exam. Any diagnosis documented as current must be coded. Must be coded. So coding from the assessment and the plan. So the assessment and plan portion of any record are the final portions of the documentation from each counter. So when you get to the assessment and the plan portion, it's usually at the end of the medical record. And it has a list of the diagnoses that they assessed, that they currently have, and it tells you the plan that they have for this diagnosis. Example, it may say diabetes type 2, stable, continue insulin, or diabetes type 2, stable, continue exercise, no meds currently. Whatever it is, it's going to have the assessment, what they assess is going to have the plan going forward. Now, sometimes providers may list problems that may have been resolved and avoid coding suspected or questionable diagnosis and do not consider lab test results. Each provider is responsible for the final diagnosis. Now, you can go back and forth. You can tell them you agree. You can tell them you don't agree, or whatever the case. But at the end, they are essentially responsible for the final diagnosis. So, any questions? Any questions so far about this chapter? Any questions? Anything you didn't understand? Now, this is what I really want to hear. What was it, maybe if anybody want to answer this question, or even if it applies, what was it that you did not understand reading through it on your own or going through it this week that came full circle for you while we're doing this lesson today? They say like a light bulb. That's why I put light bulb on the end, like, oh, okay, I got it now since we're at the end. Did anybody have that issue where it didn't really make sense as you was reading it, but it makes sense today?
Well, I had help. So I went through the whole assessment. I didn't know pretty much. It was hard for me to grasp. However, I had help, and I have a couple of friends that actually do this as well. So I actually had to sit with them and go over this again, and it kind of, and it started to make sense as they were explaining it to me. So I kind of already had that understanding, but I still needed help with the test. I don't know if we went over that yet, but number 11 is what killed me.
Okay. So you got a cheat sheet over there. You got your friends, you got a cheat sheet. That's perfect. Because I'm glad I was able to have great mentors where I can call and say, hey, I don't understand this or what's going on. So imagine my first certification being that CPC, where I have to dig into 3 different books trying to understand 3 different coding concepts, 3 different coding sets. So that's why I always recommend, if someone doesn't have their CPC yet and they're thinking about coding, that's why I always recommend this first, because you just kind of honing in on one particular subject versus breaking into the coding world with 3 different books, 3 different code sets, 3 different, things you have to learn. Okay, so anybody else before we go over the quiz?
For me, I understand better now that we done went over it, how to identify current diagnosis and diagnosis that is no longer active on the patient chart or whatever. Like, I get it now that you have explained it.
Okay. Anybody else want to say anything before we start with the quiz?
I was just going to say that some of them I was overthinking because I could see that some of them had like with or different words that stuck out to me. But when I looked at the actual code they were not there, so I wasn't sure which one to choose.
Okay, so yeah, definitely, it is definitely tricky as far as understanding what to code and what not to code. That's why everything on this quiz is important for you to understand, because this is going to definitely be on the exam. So anybody else have any questions, or just want to make sure that they got the full understanding, or just want to have any comment about chapter 7?
I'll just add to what everyone else said. For me, my struggle was number 11 also, but I'm not as comfortable with the coding as I would like to be, and I think I just need more practice. But today's session, it all makes sense now.
Okay. So chapter 7, number 1, what must be included within a discharge summary submitted as a physician provider type? So we have to have the discharge date. So the answer is C. We must have a discharge date. So number 2, a 62-year-old female seen in the office today for a follow-up on history of central right breast cancer. No symptoms now and currently on chemotherapy. Which of the following is the most accurate? Is it A, which is that personal history? Is it B, we're going to code C50.111 and tell the provider to change to active cancer at next visit? C, do we suggest that the provider update history of breast cancer to active because the patient is on treatment? Or D, C50.119? Somebody tell me what the answer is. I want to hear this answer from somebody. I'm scared to be wrong. Look, how are you gonna be scared to be wrong?
I got C.
Okay, anybody else?
I got same. The C. I got C.
Okay, anybody
I
else?
got C also. C.
Okay, so everybody want to just tell me that they on top of their coding game. Is that what everybody's saying? Okay, so the answer is C. So let's go back, let's say, okay, why it's not A? It's not A because it's not personal history, because they are currently on chemotherapy. Remember I said it does matter about medications, and if something is currently being treated, then it's not a history because you're still going through it. So we're not going to code C50.111 and tell the provider to change to active breast cancer at the next visit, because we can't tell the provider to do anything. Now we can suggest and we can come to a mutual agreement according to the guidelines or the documentation, but I can't just tell you what to change on your stuff like that. I can make the suggestions, but I can't just say, hey, go do that, you know. So we're definitely not going to do that as far as changing something on the next visit, because that means we're leaving out something wrong on this visit and we're waiting to the next visit. So it's definitely not C50.119 because that's unspecified. Remember, we went over, when you see that 9 on the end, more than likely it's going to be unspecified. So it's definitely going to be C. We're going to suggest that the provider update history of breast cancer to active. And we're going to explain that we're going to change this to active because the patient is currently on chemotherapy. Now, although they don't have any symptoms, they're still on a medication. So it makes it active because we're still treating a condition. Does that make sense?
Yes.
Perfect. So what are risk factors? Risk factors are notes about patients' known medical history or social habits that may put the patient at risk to develop a disease or condition. So it's C. It's C. So number 4, it says moderate CKD stage 3, unspecified, code N18.30, which is true. Which one would be used on the in the medical record? Would it say ruled out end-stage renal disease? Would it say assessment and plan moderate CKD? Would it say assessment and plan dialysis status? Would it say assessment and plan mild CKD? The answer, of course, is B. It's right there that says moderate CKD. Doesn't say anything about dialysis, and it does not say anything about mild. Number 5, which code is not appropriate to assign ICD-10 code J449? The answer is going to be B. Some people told me they were confused on this one, so let me give you a little explanation behind that. And I wrote out a real. Okay. So if you look in your book, so which code is not appropriate to assign? So when we say J44.9, that's going to be COPD unspecified. So COPD can be tricky in the sense of there are a lot of conditions that can be considered COPD, because COPD is basically chronic obstructive pulmonary, disorder or whatever. So that means that you're having some pulmonary issues going on. It could be asthma, you know what I'm saying? Just or regular COPD, So the thing about it is J44.9 is, like I said, COPD unspecified. Asthma is a form of COPD. It's just a more specified form of COPD. So if you look in your book, it's going to tell you, or it's synonymous with asthmatic bronchitis chronic, COPD, or chronic obstructive asthma. But chronic bronchitis is not appropriate to code J44.9. Asthmatic bronchitis, or just regular COPD, or chronic obstructive asthma, because asthma is COPD, but not chronic bronchitis, will be used with it. Now, which statement is true regarding chronic conditions? Number 6. Amputations reported in the past history should be reported as history of amputations. We know that's not correct, because we know once you get amputated, then it's not like your limb can grow back. So it's never a history of amputation. You can say, you can use your status code to show the amputation, but we wouldn't per se use the verbiage history. B, chronic conditions listed in the past medical history should never be reported as current. Definitely not there. You can code chronic conditions listed in the past medical history if they're currently being treated for, because it'll make it current. The next one, chronic conditions must be listed in the assessment and plan portion of the medical record to be reported for risk adjustment coding. And remember, we said that it can be anywhere in the medical record. So no, the answer is D. Chronic conditions reported in the past medical history can be coded for risk adjustment if there is documentation to support current treatment. 6 is D. 7. An 88-year-old male patient with history of PE, pulmonary embolism, presents to the nephrologist for a follow-up on his CKD stage 3B. Patient also has hypertension and is at risk for heart failure. 3 years ago, the patient had chest pain and a large pulmonary embolus in the left lower lobe. The patient is not currently experiencing symptoms and is no longer on anticoagulant drugs. What ICD-10 code or codes are reported? Who wants to give me what they got? What answer did you get?
C.
C.
Anybody else?
C. I got C.
The answer is C. The answer is C because we have a history of PE. And how we know it's history is because they don't have any symptoms and they're not on anticoagulants anymore. That shows me it's a true history. The I-1310 is hypertensive CKD. They got hypertension. They got CKD, so there's a combination. We wouldn't use separate codes. And so we use the I-13.10 versus the I-13.0 because the I-13.0 basically says that they have heart failure. This patient is at risk for heart failure, which means they do not have heart failure. So that's why we will use the I-13.10, which is hypertensive CKD stage, I think maybe 1 through 4, whatever. So then we're also going to code the N18.32 for the stage 3B. It's not A because A has regular hypertension. And this is how I'm going to show you a process of elimination right fast. So it's not A. We see I-10 in A. And we're gonna know as we get more into risk adjustment, if a patient has CKD and if they have hypertension, it's automatically a combination code for that. So I-10 is just simply hypertension by itself. So I would look at A, just knowing my coding experience, I can look at A and automatically know that's not it because I see I-10. And I see chronic kidney disease and hypertension, and I automatically know there's a combination code. So B, I automatically know B is not it because I see I-13.0. I know that I-13.0 is hypertensive CKD with heart failure. This patient is at risk for heart failure, meaning they don't have it yet. So I automatically know A or B is not it. So when I look at D, I see that I-10 again. So I can automatically know that D is not it because I see the I-10. That leaves me with C. Process of elimination sometimes help you from looking things up. Now you can look things up to be sure that you're sure, but like once you get into it for a while, like me, if I go to an exam and this was the very question on the exam, I can look at it from reading it, X out A, B, and D, circle C, and keep moving without ever opening up my book. Make sense?
Yes.
Makes sense how we can do that process of elimination. So if I was doing this on a real exam, like I said, I can look at this question, look at the answers, and that just saved me time because I do not have to find these answers in my book because I can look at C and show it's correct and know it's correct. So number 8, of course, is B, which is a psychiatric hospital. So number 9, 41-year-old female patient presents to the neurologist for a follow-up. The patient had a stroke 2 months ago and is experiencing left side weakness. What is or are the appropriate code or codes to assign? So we already know, and this again, process of elimination, we already know that B is not it because we see that they have left-sided weakness. So we know we're not going to use I-63.9 or whatever, which means that's a stroke. They're having a stroke in a setting. We see they're in the neurologist for a follow-up. So we know they're not currently having a stroke now. So we can X out B. We know B is not it. So we can X out C because we know C is Z86.73 is history of stroke, which means you do not have any residual effects. So now it just leaves us with A and D. So there was a process of elimination. Now when we look in our code book, we only have 2 codes to look up instead of 4. Process of elimination is very important. And the only way you can get there is just knowing and just being comfortable in knowing what you know and taking good notes, remembering things. So medical documentation reviews are used to forecast future health needs while explaining current needs and expenses. True. 10 is true. So 11, who all had problems with 11?
I'm sorry, could you, what was the thing for 9?
Number 9 is the answer is going to be A. I'm sorry,
Okay.
I-63.354. That's going to be sequela with the left-sided weakness of the residual effects. It's going to be I-69.354 is A for number 9. So we knew it was between A and D. So it's going to be A. So remember this too, I-69.30, that's just the generic unspecified sequela code. When you get to the 3 numbers after the decimal, that's more specific. That'll help as well as far as process elimination. You see how I have an I-69 and we have just 2 numbers after the dot, and then we have 3 numbers after the dot, and the one with 3 numbers is the answer. So when you're looking for residual effects, they usually have 3 numbers after the decimal. That's another thing to kind of remember for process of elimination. The I-63.30 is just like sequela effect unspecified. Like you got something going on, but I can't specify what your effect is. So number 11, who all have problems with number 11?
I did.
I
You
did.
don't? Okay, okay. So number 11, chief complaint. The patient has presented to the office as a new, and I'm gonna read it. all the way through one time, and then I'm gonna go back and show you guys what to look for in regards to on the exam and in real life or whatever to kind of cut the mess away, which you mumble and jumble, where I can skim through this in maybe about 10 seconds and know what codes I need to pick up, and I'll show you what to do. So I'll read through it first. So chief complaint, the patient has presented to the office as a new patient for 2 main complaints. The first is postpartum depression. The patient gave birth 10 weeks ago and complains of crying a lot, sleeps more than half of the day, and she is not feeling connected to her newborn baby, and states she has suicidal thoughts. The second complaint is regarding abdominal pain and diarrhea. So history of present illness, this is a 29-year-old female patient who is complaining first about postpartum depression, insomnia, and suicidal thoughts. The patient states all of this started about 6 weeks ago. Now, she is under the care of a cardiologist for the heart arrhythmia, which is controlled and stable on medications, as well as type 2 diabetes with cataract controlled with insulin. Recently, amlodipine, never pronounce it right, was added to the medication list. She also has been under the care of a psychiatrist for her postpartum depression. Regarding her diarrhea and her abdominal pain, after further evaluation, patient is diagnosed with IBS or irritable bowel syndrome. So when they reviewed the systems, 8 systems are reviewed and several are positive. Patient's past medical history, history of heart arrhythmia, diabetes, asthma, low back pain, and acute renal failure. The patient does not smoke nor drink and enjoys watching golf. Vital signs are listed. An assessment, we got postpartum depression, we got IBS, and we also have multiple chronic conditions. The plan regarding her postpartum, she's been prescribed medications by her PCP, and RX was sent to the pharmacy for the IBS. So, which codes, what ICD-10 codes are reported? So I want to hear some of your answers, and I'm gonna tell you why it's not them. Let's go. What's some of your answers?
I would pick up the diabetes with cataract for one, and also the IBS because the physician confirmed that she had IBS. That was the abdominal pain is actually the reason, and the diarrhea is the reason for the IBS.
Perfect. Perfect. So let me show you a little thing when you're reading these long assessments like this, what to do. So it's great to have a highlighter. When you're going to take your exam, make sure you take highlighters with you. I love highlighters. So as I'm going through this medical chart, what will stand out to me is what I'm looking for. Even we're reading all this blah, 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 all this mumbo jumbo or whatever it is, I'm looking for what's wrong with this person. I don't care how old they are right now. I don't care if you crying or whatever the case. What are they saying wrong with you? What do you got? You know, that's what I'm looking for. So in the chief complaint, I would have highlighted postpartum depression. This is what the patient is kind of pretty much telling me what's going on and crying and this. So I will highlight that. I will also highlight the abdominal pain and the diarrhea. And the reason that I will highlight it is because if I don't further down the medical record see a diagnosis, then I may have to code these as signs and symptoms if I don't find a diagnosis. Because remember, we're only going to code signs and symptoms when there is not a diagnosis. But when we have a definitive diagnosis, we're not coding for signs and symptoms. So I will make sure I highlight abdominal pain and diarrhea in case they have to code it, in case we don't find out why it's, you know, the diarrhea is present or the abdominal pain is present. So in the history of the present illness, I'll highlight postpartum depression again. And you see how insomnia and suicidal thoughts are like symptoms and signs of postpartum depression. So I don't have to code for the insomnia. I don't have to code for the suicidal thoughts, even though that, you know, although there are codes for it, because those are signs and symptoms of the depression. Now this is, oh, here it is. This is an example of overcoding. I'm coding for the insomnia, I'm coding for the suicidal thoughts, and I'm coding for the postpartum depression. That's overcoding. Now everybody get a clear picture of what overcoding is with that example. Because I'm coding signs and symptoms and diagnosis. I'm duplicating, I'm overcoding, overdoing them, overthinking. Make sense?
Yes.
So that's what overcoding is. And upcoding is when you're trying to use a better code to try to get more money. So I would then highlight again the postpartum depression. And then I'll highlight the heart arrhythmia, controlled on medication. I'll highlight the diabetes with cataract, the insulin. So with the review of systems, I'll go down here, I'll check out what they reviewed, and I'll look at the rest. So let's get to the answer. So I know it's not number one. How can I automatically look at this and see that it's not number one? What lets you know that it's not number one?
The E11.9.
Perfect. Perfect. The E11.9 lets me know this is not it. Because I just said they got diabetes with cataract. So I already know they got some, and they take insulin. So that's a complication in itself. Because if you didn't have any complications, you wouldn't be taking any insulin. Remember, I said complications is driven by medications, DMEs, and things like that. So how can it be not a true complication if you're on meds? It's got to be complicated. That's why you're taking medicine for it, to keep it from being complicated. So number one, this number A, I will automatically know A is not it just because I see that E11.9. Now, I still would look it up, but this is just me, now you're not, this is me. I would know D is definitely not it because this person had too much going on for just 2 diagnoses. Now, I'm not saying it's unrealistic. I'll put a question mark there and kind of let that be the last one I look up, because with all this stuff this patient going on, it's probably more than 2 diagnoses that's in this whole thing. Make sense?
No.
Does that make sense? It's just too much going on for just 2 diagnoses. Now, I'm not saying that, a chart can't be long and you have 2 diagnoses, but it's rare. You got all this stuff going on and you just got 2 diagnoses. So I kind of know for me, not for you yet, that I already know A and D is not it. So let's go on B and see which one. So how many people chose C? Anybody chose C?
I shall see.
Okay. Anybody else?
I didn't.
Okay. So the answer is going to be B as in boy. And the reason it's not C is because, remember we were talking about the past medical history list? They do have asthma, they do have back pain, they do have all this other stuff. However, it was not addressed and assessed, and it's not saying that they're taking medications currently or anything for it. I cannot support that it's still going on right now. So when I go back to all those notes I just read, when it says past medical history, it says the patient has a history of heart arrhythmia. They have a history of diabetes. They have a history of asthma, low back pain, and acute renal failure. I don't have any documentation about the asthma. It doesn't say anything that they're still currently on asthma medication. But it does tell me that they currently are on medications for their arrhythmia and they see a cardiologist. It doesn't tell me more specifically about the back pain or the renal failure. So I'm not gonna code for that because I don't have any documentation. What's documented in this medical record for me to substantiate using asthma, low back pain, and acute renal failure? What's in the medical record that allows me to use that? You see anything?
No, we make a lot of,
So what do you see in a medical record that allows me to code for the diabetes?
Control with insulin.
There we go. So what's in a medical record that allows me to code for the heart arrhythmia?
Controlled and stable on medication.
What allows me to use the IBS? Irritable bowel syndrome.
Patient is diagnosed with irritable bowel syndrome.
Perfect. And how can I use the postpartum depression?
She being seen by a psychiatrist for it.
So where in the documentation does it support the asthma, the low back pain, and the acute renal failure?
It doesn't, it just say history of.
So if I don't have anything to support for the current visit that we're on right now, we ain't talking about no past, we're talking about the visit you are on today. I don't have anything to support the asthma. I don't have anything to support the back pain. I don't have anything to support the acute renal failure. So I cannot code it. The answer is B. Does it make sense to everybody?
Okay, I have a question.
Yes.
It did make sense to me.
Come on, it did not make sense to you?
I get why you got the answer you got. I guess where I went wrong is I was going by what they came in with their chief complaints.
Okay, so if we're
I
going
didn't
in,
understand why we had to code for the type 2 diabetes with cataract. That's the part I don't understand.
you don't understand why we're coding for the diabetes?
Yeah, only because it's in the part of the history.
And you remember we said we can code from anywhere in the medical record. As long as we have the supporting documentation to show that they're currently being treated and this condition is current and not in the past, that we can code for it. So we see that this patient is currently being treated and is controlled with insulin. So we have to capture this code because they currently are having a problem with their diabetes. They're currently on insulin for it.
So it's still ongoing.
It has to be because it's controlled with insulin. I'm controlling it with medications. So I'm treating it. You're getting treated for it with your insulin. That's how I know it's ongoing. Now, if you did not have any insulin in your chart, or it didn't say anything about it's ongoing or it's controlled, then it wouldn't be current. But I'm seeing here where it's saying it's controlled with insulin, which means you're taking insulin almost every day to control it, which means we're still treating it, which means it's still here.
Okay, so as long as it's being treated, or like you said, controlled, then we would still code for it.
Yes, why would you not code for something that's still here, that's present, that's treated? That means I'm missing out on a diagnosis. If it's something wrong with you and we're treating you, how can we leave it off of the medical record? If this is something that's wrong with you. So that means we saw it's wrong with you. We see it's going on. We see you're getting treated for it, and we're just gonna leave it off the medical record like we don't see it.
Okay.
That makes sense now? If it doesn't, let me know.
I'm gonna make it make sense.
No, you can't make it make sense because it ain't making sense right now.
I think I gotta get past what the law. I looked at the chief complaints. So of course I coded for the postpartum and the diarrhea, the irritable bowel syndrome.
So the name of this portion that the diabetes in, it says history of your present illness.
Right.
It's basically saying this is what's presently ill with
still
you.
Going on. Okay.
Yeah. It's a history of what's presently going on. I'm taking a complete history of what you got going on right now. Don't let the word history throw you out.
Okay.
So because it says history, a history of present illness. History means a record. So you're basically saying this is a record of your present illness. So these are the things that are presently going on with you. And if they are presently going on with you, then I have to record it because I have to capture what's wrong with you. That's why you're here.
Right. Okay.
Does it make, no, you don't be saying okay just so I can be
No,
quiet.
it does. It does make sense. It does make sense.
If it don't, then who is this?
This Dirois.
Who?
Dirois.
Okay. Oh, okay, Dirois. Okay, I'm sorry, Dirois. Now, if it don't make sense, you call me Dirois. Now, don't be talking about so I can move on.
No, I get it because what I did was to kind of understand, because I don't know the codes like that. I went through all the codes, just to kind of make sure that I knew them and what they were for and everything else like that. And what I didn't want to do was overdo it, but in this one, I underdid it because, like you said, this is stuff that's presently going on with the patient.
Right, and how you know it's presently going on because it says they are on insulin, which means I'm presently treating it. So we have
that history, that the history, you know how you have to take
threw
person's
you out.
history. Yeah, because it was history of the present, not history of elongated things that had happened in the past. Yeah,
right. There we go. So it's pretty much a record of your present illness. Because you know, history means it's just a record. So the word just threw you out.
Right.
And that's a prime example of what I mean in coding, where one word can change the whole meaning of what's going on.
Right.
One word. One word can change the whole meaning. So of course the arrhythmia is here because they're seeing a cardiologist for their arrhythmia, and it's controlled and stable on meds. So that's why we will code for the arrhythmia as well, because it's currently being treated. So we will not code for the asthma, the low back pain, and the acute renal failure because there is nothing in this documentation that supports it other than they had it in the past. We're not going basically off everything you had in the past, so we'll be coding everything every time. We got to code what's presently wrong with you and what's documented that's presently going on. Okay. So number 12, what are the 3 main components of an office visit? There's going to be history, exam, and your MDM. 13, what is the medically necessary reason for an encounter with a patient, with a physician in any setting? That's going to be your chief complaint. That's the reason why you have an encounter. So the patient has a history of smoking cigarettes and occasionally having drinks. What portion of the medical record would the aforementioned be listed in the social history? Because that's your social business. What is evaluated during the physical exam? I want somebody to answer that. What's evaluated during your physical exam?
I put each body area or organ systems to cooperate. Wait, I can't even read. Okay, each body area or organ systems to correlate with the chief complaint.
Perfect. So what's evaluated during the physical exam? So your body systems and your organs. And keep it short and sweet too, Kevin. That was the correct answer. That was right. But sometimes as coders, we tend to overthink things. So kind of be as cut and dry as possible with everything, how you're thinking about it. So your answer would be body systems and organs. What's evaluated during a physical exam? Body system and organs. And they do that with your review of systems, of course. So 16, a 52-year-old female patient presents to the cardiologist for a follow-up for a heart attack, which is a myocardial infarction and involving left main coronary artery that occurred 5 weeks ago. Now she's feeling fine, she's in good spirits, and she's excited to return to gardening classes. What ICD-10-Cm code could be assigned? The answer is C, I-25.2, which is the old MI. So this is one way, and let me tell you how I learned kind of my ICD-10 book. I know the I codes deal with your circulatory system. You know, as far as you know, your high blood pressures, your strokes, and your DVTs and your pulmonary embolism. So that's how I learned. That's how I know my I code is circulatory. My E codes, I know that's your endocrine, because I know this the diabetes in there. If you have vitamin deficiency, that's in your E's. So I know that's my endocrine system. I know my neoplasms is my C's. I know this cancer, C for cancer. That's how I remember. E for endocrine. That's how I remember. I know my Z codes are all my status codes. It's just gonna tell me the status of the patient. I know my N codes dealing with maybe like erectile dysfunction or dealing with urine incontinence and things like that. My O codes are my obstetric codes. I know they for pregnancy. My P for newborn, pediatrics. So this, I kind of find an association to kind of remember the category. No, I don't know all of the, as far as all of the codes by heart, I this or I did or no, but I can pretty much, if you tell me it's an endocrine disorder, I'm going to the E's. If it's a status code, I'm going to the Z's. If somebody got some musculoskeletal issues, I'm going to the M's. You know, if this is a pregnancy code, I'm going to the O's. You know, so that gives me a start in knowing where to look. And then help me start narrowing down of memorizing, being very good with codes, because I first remember the sections that certain things are in. High blood pressure, oh, I know that circulatory got to be the I. You know, viral diseases like sepsis and AIDS, oh, this got to be the A and B's. Parasitic stuff, that's A and B's. You know, so I just kind of learned it like that. So the provider, number 17, the last one, the provider can document a diagnosis solely from the patient's account of their medical history without clinical or diagnostic results. False, 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 false. I can use their information to validate what's going on, but not their information alone.